So remember when we talked about cognitive behavioral theory and in the beginning of the semester, and when we've talked about cognitive behavioral interventions at other times in this semester, that most of what the focus here is on in terms of etiology, disruptions to how we're thinking and how those disrupted thoughts lead to disrupted behavior. And then treatment is going to try to get the individual to recognize what their thinking is, especially their automatic thinking, and how that is leading to behavior so that they can unlink those and create bigger pauses in between thoughts, emotion, and behavior. And so with the eating disorders, the cognitive factors that get focused on a lot is the body image disturbance, which is clearly a cognitive factor, and also just the fear of fatness and the fear of being fat. And then we also see, especially in people with anorexia, but in some cases across the board with all of the eating disorders, a need for perfectionism and feelings of personal inadequacy. And if you think about this from a cognitive behavioral point of view, right, that this is a bit of an irrational thought. The people who need to be perfect are often illogically or irrationally judging themselves harshly or holding themselves up to a standard that is difficult or impossible to maintain, and believing that they need to be that in order to be adequate. And then there's also this awareness and increased sensitivity to criticism, both about how you look, but in more general ways, and it ties back to that need for perfectionism. And so let's think here. I want you to pause here for a moment and think about what we've talked about in terms of that Laura Hill video and what we talked about in terms of serotonin and dopamine, and what we just talked about with cognitive behavioral etiology, and think about what do you think treatment is going to look like. And you can pause the video for as long as you want to think about that yourself and challenge you. And when we're in our discussion together, I'm going to ask you to offer up ideas about that, though we will also look at the next slide and talk about that some. So, right, so you probably guessed, and hopefully you paused and thought, but you've probably guessed that if serotonin is disrupted and we're thinking there's not enough serotonin, that probably we're going to want to treat with medications that are going to increase available serotonin, and that is largely going to be those SSRIs, which we've talked so much about. And that also, similarly, if we're talking about disruptions to cognition, that we're going to use cognitive behavior therapy, that's CBT, to address the beliefs, the assumptions, the thought patterns that are supporting and leading to the problematic behaviors. And we may directly address the disruptions to body perceptions, but outside of that, a lot of the majority of the symptoms for these three disorders are behavioral symptoms. And so thinking about what situations, what thoughts, what emotions are likely to lead to those disrupted behaviors, trying to find patterns, trying to see help the person see those patterns, and then helping them to catch themselves at the beginning of a cycle where they're starting to feel or think something that's going to lead or might lead to the disruptive behavior, so that they can address the thoughts and the feelings and maybe head off the behaviors. And so that's all going to be a very important part, and almost all therapy for eating disorders is going to pair a medication approach as well as a CBT approach. And then many, many approaches to eating disorders, especially if the patient is a teenager, are going to include family therapy. And probably the oldest way of understanding eating disorders is through what's called a family systems point of view. And the family system point of view used to assume, or still does, I suppose, assume that the designated patient who has the eating disorder is just showing the symptoms of a disrupted family unit. And I think that kind of strict and fairly psychoanalytic approach to thinking about family dynamics is not the main approach we usually see anymore. But we often do assume that family is going to be very, very important in supporting successful treatment, especially if you're living with the family members. And if you think, even in your own lives and families, of how emotionally connected family discussions of food can be, and whether somebody's eating or not eating, or what they're eating, or what their body size is. Those often become family discussions in many families. And so getting at the underlying tensions and teaching families how to talk and think about food and bodies in healthier ways is often a really important part of treatment. So we're going to end there. Obviously, we have online discussion to flush some of this out a little bit more, and so think about what your questions are, and we'll take it from there.